Good morning, everyone, and welcome to our symposium. And also for many of you, welcome to Toronto. This is a symposium titled Clinical Judgment, Multidisciplinary Perspectives, and it comes just before the International Philosophy of Medicine Roundtable, which is being held here in Toronto over the next couple of days for the first time. I'm Jonathan Fuller, one of the organizers of this event, along with the gentleman to my left, Benjamin Chin-Yee, who's celebrating a birthday today, incidentally. And we wanted to start by acknowledging this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have this opportunity to work on this land. I want to also make some thanks to Ben for helping me organize this event, Ross Upshur, our co-organizer for the International Roundtable, as well as Manny Gitterman, the managing director for the scientific Collaboratory at Bridgepoint, who's responsible for all the logistics of this event, and without whom this wouldn't have been possible. We also want to acknowledge a number of sponsors of this event, including the Faculty of Medicine, who was generous enough to help us put this together, the Ruggles family for support to the Robert and Francine Ruggles Health System Research Award, as well as the Dalla School of Public Health, the Medical Alumni Association of the University of Toronto, Bridgepoint Active Healthcare, and the Lunenfeld Tannenbaum Research Institute of the Sinai Health System. So why did all these institutional bodies come forward to help us put on a symposium on clinical judgment, and why bother with a symposium on clinical judgment in the first place? So I think it should be hopefully uncontroversial that clinical judgment is an essential competency or task of any clinician. It may be a bit more controversial, but I think still plausible, that it represents the fundamental task or competency of any particular clinician. And yet the philosophy of medicine, which is the field that we work on, hasn't paid all that much attention, with a few notable exceptions, to this very important topic. So our first aim is really to stimulate interest in clinical judgment among our community. But I think it's fair to say that clinical judgment is a topic that's rich enough, diverse enough, and important enough to benefit from analysis from multiple different disciplines, many of which are represented here today. So to name a few, disciplines like medicine, psychology, clinical epidemiology, medical education research, and the social sciences and humanities more broadly, some of which have a greater tradition of exploring clinical judgment and clinical reasoning. So our larger goal here is actually to stimulate a conversation across disciplines. And that's why we called it Clinical Judgment, Multidisciplinary Perspectives. I'll also mention we have a couple of hashtags for the event, hashtag Clinical Judgment 2017 and hashtag PhilMed 2017 for all those out there tweeting. And before I go on, I also wanted to just say a couple of words about clinical judgment. I think part of the task today will be wrapping our heads around what clinical judgment is and what are its dimensions. But I wanted to start us off with a couple of ideas. So clinicians of all stripes are responsible for cognitive processes and inferences in various areas, like diagnosis, where they diagnose a patient's disease or problem, prognosticating, the act of predicting what will happen to a patient in the future, therapeutic reasoning about how a treatment will impact a patient, and decision-making, tying it all together towards a particular goal or plan of action. So I think these are some of the dimensions of clinical judgment, but as you can see, this word cloud is quite bare and actually quite sad-looking. So I hope the symposiasts today will help us to fill in this word cloud. I'll be adding to it throughout the day with themes that emerge, and we'll see what we end up with at the day's end.
Perfect. So thank you, John, and thank you for the introduction. So we're excited to move ahead with an exciting lineup of speakers and panels as well today. We should note that there's going to be time for questions after some of the talks, but there will also be plenty of time for questions during the panels. And we're going to see a range of topics covered, which I put up here. Topics from a Bayesian approach to clinical judgment, to medical decision-making, to the role of clinical experience, as well as implications for medical education. And we're excited to hear a number of different perspectives from various disciplines on the topic of clinical judgment, as John mentioned. And we're going to be seeing approaches to this topic from different angles. You might find that some speakers take more descriptive approaches to clinical judgment, attempting to describe the work of actual expert clinicians working in the field of healthcare. Others may take a more prescriptive or normative approach to clinical judgment, offering perspectives on how clinicians ought to perform clinical judgment and what clinical judgment ought to be. Some may fall anywhere sort of along this spectrum from descriptive to normative approaches. But I just wanted to introduce this distinction so that the audience can keep it in mind during the speakers and the panels today. So I'm going to hand it over to John, and we're going to get on with our schedule today. Thank you.
Okay, so without further ado, I'll reintroduce Benjamin Chin-Yee, a newly minted physician at the University of Toronto, and Ross Upshur, physician, public health scholar, bioethicist, among other roles at the University of Toronto as well.
Excellent. Thank you very much, John. So the aim of our talk, as the first talk of the symposium here today, is to highlight some of the approaches to clinical judgment that we find in the literature, and also as an indication of what's to come for later today. And we also hope to articulate how we envision these different approaches fitting together. But before we dive into the topic of clinical judgment, we want to start off by defining the terms. So the definition of clinical judgment is somewhat contentious. Here we're employing somewhat of a broad definition, where we mean clinical as relating to the world of practice, being based in encounters with patients, families, and caregivers, and related to the health of patients. By judgment, we are referring to the heterogeneous collection of reasoning tasks, ranging from formulating a differential diagnosis, communicating a management plan, communicating a prognosis, as John mentioned at the very outset. And it also necessarily considers multiple sources of information and multiple constraints on a decision. So to ground this discussion, we want to start off with a clinical case. And this is a typical case that one might see in primary care or internal medicine. This is the case of Mrs. Scott. Mrs. Scott is an 84-year-old woman who is seen at clinic with her daughter. She has multiple medical conditions, and the most recent stressor in her life recently has been the loss of her husband 15 months ago. She has somewhat of a precarious financial situation, and her daughter's concerned about functional decline. She's been eating less, she's been forgetful, she's worried that her mom has dementia. The patient herself admits to ongoing sadness and jokes that everyone her age has problems with memory. I want you to keep this case in mind, and we're going to return to it at the end of our talk. So let's go to the question, what is clinical judgment? And highlight some of the themes that we find in the literature. Some have approached the topic of clinical judgment from the lens of cognitive psychology or cognitive science. These approaches have posited different cognitive processes involved in clinical judgment and have discussed notions of heuristics and cognitive biases. And we're going to hear about these in some of the talks later on today. Statistical approaches have become really dominant perspectives in clinical judgment, and in large part this has been popularized by the evidence-based medicine movement. And you'll be hearing more about this during our talk and also other talks today, including Jonathan and Luis's talk on Bayesian approaches to clinical judgment. Other approaches we find are the ethical, moral approaches, as well as narrative approaches. And what these approaches share in common is that they emphasize the ethical and value-laden dimensions of clinical decision-making, and they view the clinician as a sort of moral reasoner. They draw on concepts often of practical reasoning or phronesis, and they focus on arriving at what is called a right clinical decision for a particular individual in light of values, cultures, and other contextual factors. And we should note that there's often a blending of these approaches, and really what we're putting up here is just a framework for thinking about our talk and some of the other talks today. So what we want to emphasize in our talk is this tension that we find between the narrative interpretive epistemologies, the virtue-based epistemologies, and the statistical evidence-based epistemologies. This is a tension that we find in the philosophical literature, but it's also one that we encounter in clinical practice and medical education. As a trainee myself, I've often felt this tension, being told again and again the importance of listening to a patient's story, of attending to the subjective experience of illness, while at the same time being quizzed about likelihood ratios and sensitivities about specific components of the clinical exam. And so, note, by highlighting this tension, I'm not trying to emphasize a dichotomy, and really what we're trying to do, and what we hope to demonstrate in our talk, is that clinical judgment is really a pluralistic practice that necessarily involves many different approaches. So with this framework in mind, I want to now examine some of the statistical approaches to clinical judgment. And really one of the seminal figures in this field is this physician here, Alvin Feinstein. So Feinstein, he wrote the book on clinical judgment in 1967, and this book was tremendously influential for thinking about statistical quantitative approaches to clinical reasoning, and it remains a valuable source today. He also followed it up in 1987 with his book Clinometrics. And so Feinstein's aim was to dispel the mystique surrounding clinical judgment. He wanted to make it transparent and teachable. He advocated for a scientific approach to clinical reasoning that would be based firmly in clinical observation and measurement, but he thought that we shouldn't pursue the scientific ideal by turning to paraclinical domains, as he called them, away from the clinic. And he focused on developing more robust, standardized clinical measures for diagnosis, prognosis, and treatment. He breaks clinical judgment down into two processes. Therapeutic reasoning, which focuses on treating the patient as a representative case of disease, and environmental reasoning, which focuses on individualizing management of an illness for a particular patient. And this might encompass some of what we call the humanistic aspects of clinical practice. What Feinstein wrote is, it includes the choice methods of communication, accommodation, and human interchange that will best enable the sick host to bear the burdens of both ailment and treatment. Feinstein argued that it's a clinician's privilege and power in clinical therapy in his ability to make both therapeutic and environmental decisions concomitantly. The clinician combines treatment for the patient as a personal case of disease with concern for the patient as a personal instance of mankind into the unified mixture that is clinical care. So what we want to emphasize is that Feinstein's clinometrics is explicitly an approach, and he acknowledges this, to therapeutic reasoning, and it treats patients as instances of disease. And he recognized that this left out important domains of clinical evidence, namely what he called the environmental and host data. And so clinometrics really is one aspect of clinical judgment, and it's always implied in light of other contextual factors. Clinical judgment necessarily considers the totality of the evidence in order to arrive at clinical decisions. So whereas Feinstein was a major influence in early clinical epidemiology and evidence-based medicine, he actually later became an outspoken critic of the movement related to its narrow definition of evidence and its rigid hierarchy in particular. And now 50 years later, we'd argue that contemporary evidence-based medicine actually shows a departure from Feinstein's original clinical epistemology, and that it privileges objective paraclinical data and often devalues the environmental and host factors, or the value-laden humanistic aspects of clinical practice. So this is a typical text which promotes this evidence-based medicine approach to clinical reasoning. This is from the Journal of the American Medical Association, Rational Clinical Examination. And this book has been tremendously influential in clinical practice as well as in medical education. It was required reading during my medical school. And in this text, we find approaches such as this one here. This is a very popular approach. Does this patient have an alcohol problem? And it produces a questionnaire with likelihood ratios assigned to different responses. And this is all based on clinical studies that will allow you to determine whether or not your patient has an alcohol problem. These texts have become very popular and they've proliferated, and I think it's in large part because this algorithmic formulaic approach is somewhat easier to teach and easy to examine. And in these sort of texts, we find statements like these. It's hard to escape the implicit conviction that laboratory and technologic data are more objective and therefore more scientific than the subjective information gathered by listening to a patient tell his or her story. So this seems to be a departure from what Feinstein originally spoke about in clinical judgment, and really emphasizing the paraclinical data as privileged inputs into clinical algorithms. Now, to be fair, there have been attempts to add nuance to the EBM account. This shows a change in the EBM decision-making model from 1996 to 2002, and this is in an article by Brian Haynes and Gordon Guyett. And what's different in the 2002 diagram, which is on the left side there, is that we have a circle now for clinical state and circumstance as well as patient preferences and actions. And so clinical expertise now becomes about integrating these different components. But what we'd argue is that this bubble integrating these aspects really presents a bit more of a challenge than these authors might acknowledge. And whereas there's been quite considerable emphasis on research evidence in the evidence-based medicine epistemology, how to integrate clinical state and circumstance as well as patient values needs further elucidation and elaboration. So now I want to move into talking about some of the narrative value-based approaches, but before that I want to discuss briefly what we see as the latest extension of the data-driven statistical approaches to clinical judgment. And this is big data and AI, also known as machine learning, also sometimes called predictive analytics. And obviously we don't have much time to discuss this in great detail, but very briefly, what it involves is rather than using top-down algorithms or rules that are put into place by programmers, this technology, what it leverages is technologies such as deep learning or artificial neural networks, which basically are simulations, computer simulations of how human neurons behave in order to extract rules and patterns from massive data sets. So we see this as sort of the latest trend in the data-driven statistical approaches to clinical judgment. And this approach has really generated considerable interest in clinical medicine. We see almost articles like this coming out almost on a weekly basis about computers replacing doctors, about the rise of machines in medicine. But it's not limited to the popular media, and we see this also in the academic literature. This is an editorial from the Journal of the American Medical Association. In this article, Eric Topol writes that it's easy to envision that predictive analytics, using all the relevant metrics for an acute event, such as an asthma exacerbation, seizure, heart failure, decompensation, severe depression, or autoimmune disease symptoms, could warn individuals and their physicians before these events occur. We see an almost more extreme statement in another editorial on predictive analytics. These authors write, hypothetically, if all past, present, and future predictors and processes that contribute to future events were known and quantifiable, algorithms could be constructed that produce perfect risk estimates for individuals. That is, they would predict with perfect accuracy whether an event would occur or not in every individual. So this is obviously a misrepresentation of clinical reasoning and clinical judgment, and it's actually prevalent in the literature, and it demonstrates a fundamental misunderstanding about the extensive uncertainty that arises from the nature of the clinical encounter, as well as the limitations of medical knowledge. So I'm now going to turn it over to Ross, who's going to discuss some of the limits of big data and AI, and he's going to articulate a more pluralistic view of clinical judgment. So thank you.
Thank you, Ben. It's a real pleasure to be here today. And as I was sitting looking out at the room, a sudden feeling of terror overcame me at the sheer brain power that's in this room. So I'm going to have to be very careful indeed about what I say. So I'll do my typical thing and apologize for my incoherence in advance and defer to the wiser people in the crowd. So clearly there's a lot of move towards this emphasis on big data, and there's been some pushback and some criticisms of this too. And what I'm going to walk through is some of the limitations of big data and then sort of step back now. So we've gone up the hill and we'll come down the hill back to the case through a consideration of this. So of course, data systems are limited by the data itself, and if the data is unreliable or if the taxonomies of data are incorrect or there's not enough theoretical specification, you're going to have problems with big data being as accurate and meaningful as you want it to be. And so Coveney and a group of people recently published in Philosophical Transactions of the Royal Society a set of constraints and challenges that big data face. But go back to since we're in Canada, we may as well quote famous Canadian physicians. Sir William Osler wrote that medicine is a science of uncertainty and an art of probability, which is kind of a nice catchphrase that will help us to move through to why judgment is important in clinical medicine and why it will always be with us. I'm also going to steal brazenly from one of our speakers. This won't be the first time in my talk that I'll steal. It's kind of almost like begging forgiveness. But Benjamin Jabilovic, who's here with us today, in what I think is one of the best essays on uncertainty in clinical medicine, provides this kind of template diagram to help you conceptualize this. And so on the one side, you have complete ignorance, which many of us probably dwell. And on the other side, you have certainty. You have the present state of knowledge, and you have the perfect state of knowledge. And you have reducible uncertainty. And a lot of the machinery of research of various types and stripes is meant to take us from the present state to move us towards a better state of knowledge. But even in that better state of knowledge, there is statistical and irreducible uncertainty. And much of what, so the person that Benjamin quoted about knowing the perfect state of knowledge probably doesn't believe that there is such a thing as epistemic irreducible uncertainty. That is, ineradicable, ineliminable uncertainty that we can't get rid of. And one of the things we might want to talk about is whether that state of affairs actually exists. It's a very long discussion in the philosophical literature. But if, in fact, that state of affairs does exist, then there's always going to be a room for judgment because there will always be uncertainty. And furthermore, Jabilovic and his colleagues came up with a very nice taxonomy of different types of uncertainty. So epistemic uncertainty has dimensions of measurement error, and those in the room who've done a lot of work in measurement theory or have tried to develop clinical tools know that there's all sorts of different types of measurement error. Systemic error that can come in through bias, random error, and uncertainty. One of the important things about the application of any form of model in clinical practice is the uncertainty about applying a class probability to a case, to an individual case. And it's not entirely clear that big data or any of the mechanisms that we have are in the condition of actually, some of them may actually be increased with the advent rather than decreased. They may increase uncertainty. Secondly, you have, did my thing go dead here? Of course, no. Subjective uncertainty. So a lack of information when information may exist, that's a state of ignorance, but lack of information because there's incomplete understanding, or there's that gap between what we know currently and what we probably should know in a better state. An overabundance of information. The whole architecture of systematic reviews is meant to reduce that abundance of information, but of course, if you work in clinical practice, you know that there's a gazillion systematic reviews in the Cochrane collaboration databases that you need to navigate through. And they're also supposed to be a mechanism of reducing conflicting evidence, and actually, if you spend a lot of time reading the conclusions of Cochrane systematic reviews, they almost inevitably conclude that we need actually more evidence. So we're not actually much better off there. And then one of the important things as we move towards the actual application of all of this into practice is degrees of belief, values, and preferences, how patients see things, what they believe. So degrees of belief can be informed by information, but values and preferences may be of a different category to think about. Okay. Great. So there's the ideas here that big data will solve these problems. I think in some cases it may decrease it. It'll certainly give us more information, but that abundance may actually increase uncertainty, and it certainly may lead to an increase in conflicting uncertainty. And it may be neutral with respect to beliefs. In fact, there's some concern that a lot of these machine learning technologies are just baking biases into our way of thinking in the first place, because somebody has to program the machine to begin with. Model uncertainty, as everybody who likes to study philosophy and science, all models lie, but they lie in creative ways. Some are more productive than others. And then issues around linguistic uncertainty, numerical vagueness. I see Jeff Norman out there who once wrote a lovely piece on how different people, I read that way back, that's on how different adverbs and adjectives are used to different quantitative estimates of uncertainty and probability terms. Ambiguity, I'm going to add ambivalence, because as a practicing physician, the one thing that I've never seen well modeled is ambivalence. Patients are just sort of, well, I don't know, should I do this, should I not do this? One day they're this way, one day they're the other way. And that's a form of uncertainty that relates to context dependence, which is when we get to how we actually apply things in practice. And our argument is that perhaps artificial intelligence will actually not help with any of these things. In fact, the uncertainty may be increased in the presence of these types of uncertainty. So we're now going to move back into the narrative and virtue-based epistemologies, and Catherine Montgomery. So here we are, another speaker later today, who's written a brilliant book called How Doctors Think, and I see Michelle Shamey in the audience. And we actually did a review when Jerome Groopman wrote a book with the same title, How Doctors Think. We titled our review, Do Doctors Think? But the editors actually changed it. They wouldn't permit it that. So we went through Groopman's book and concluded that probably Catherine's book was a much better account of how doctors think. So it talks about how narrative and interpretive skills are actually fundamental to the practice of medicine. And it's like Ben was saying earlier, this tension when you're told to be patient-centered is to give your mind to the presence of the patient and their history and their story and their narrative and the particularities of their life and circumstance, and integrate that somehow, that case, with these general level, population level considerations that we call data, and how we actually navigate that. And clinical judgment requires practical reasoning, and good practical reasoning should be an exemplification of phronesis, or practical reason. So phronesis, for those in the room who aren't philosophers, was originally discussed by Aristotle in the Nicomachean Ethics a few centuries ago. But Professor Montgomery refers to it as a flexible interpretive capacity that enables moral reasoners to determine the best action to take when knowledge depends on the circumstance. So we're always in this dialectic between the general and the particular, and taking a variety of different inputs into thinking about what a wise decision would be for the care of a particular patient. Ed Pellegrino, who was a long time at Georgetown in bioethics, said that clinical judgment can't ignore the ethical and moral dimensions of the delivery of care. He said there's always three questions that you need to ask. What can be wrong with the patient? What can be done? But the exercise of judgment actually starts to come in when you start to think about what should be done. What can be done could be quite wide, and anybody who's cared for patients knows there's a multiplicity of things that you can do. You can order every test in the book, but should you order every test in the book, should you prescribe every medication, is where you start to take that integration of evidence and particularity into account. One paper that I've been particularly influenced by is by James Markham, who's a very thoughtful philosopher. He wrote and published this paper in Theoretical Medicine and Bioethics. Jeremy, were you the editor at the time this paper was published? Or? Editor of the journal.
No, I was never the editor of the journal. I may have been the, I think I was the associate editor.
Yeah. So he talks about an epistemically virtuous clinician instantiates and exemplifies two particular types of virtues. Reliabilist virtues, which relate to their, physicians and clinicians need good sense perception. I think, we were taught apocryphally that you would actually have to smell and taste the urine to determine the level of, whether the person had glycouria. And so we actually, have any of your professors taught you to go into a room and smell?
Yeah, well, on occasion.
Oh, on occasion. So our sight, our smell, our touch are actually important instruments of our judgment. So our sensory and perceptual faculties, memory, intuition, our capacity to be good inferential reasoners, insight, introspection for cognitive and conceptual. So that's kind of on the intellectual virtues. Then there's the responsibilist virtues. These exemplify the ethical context of care: honesty, courage, open-mindedness, humility, fairness, curiosity, tenacity, and integrity. So we believe that these relate back to evidence, and I'm shocked to realize that it was in 2002, which is 15 years ago, we published a paper in Theoretical Medicine and Bioethics on the virtues of evidence. The definition of evidence-based medicine was invoking terms such as conscientious, explicit, and judicious use of the best evidence in making decisions about the care of individual patients. When I read that, I was struck. Well, what do these words actually mean, and why were they chosen? And having had the great fortune of David Sackett as my mentor at medical school, I emailed him. I said, Dave, why did you choose those three words? He wrote me back and said, Ross, I don't talk about evidence-based medicine anymore. I've retired from this. Ask Brian Haynes. So I wrote Brian Haynes. I said, Brian, why did you choose these three words? And he said, well, they kind of sounded good. And I see Jeff laughing. But we thought they actually had some meaning and that they were actually trying to pick out certain virtuous aspects of a good clinician. The other thing that we want to do is we want to contextualize narrative and historical evidence as evidence in its own right. So Ben and I, about 2 years ago, I was supposed to be working on something else and came across Collingwood's book, Robin Collingwood being an Oxford philosopher, on the idea of history. And he had a whole chapter on historical evidence, and that kind of stopped me in my tracks. And I started to think, well, maybe there's something here for medicine. Is there any way in which we can use the concept of historical evidence to legitimate types of evidence that we would usually exclude? And he famously argued that anything is evidence which enables you to answer your question, the question you are asking now, and directed us to the logic of question and answer. And when you think about a clinical encounter, it's often somebody coming to you with a question about what's wrong with them, and you ask them questions to help clarify what might be the case. And so the logic of question and answer actually starts to focus on how we can structure a logic of the clinical encounter. We also want to push this a little further into the notion of hermeneutics. And so Hans-Georg Gadamer famously argued that the question was the primordial way to start the search for any meaningful relationship or answer. And so he says the path of all knowledge leads through the question, and if questions lead us to the pursuit of the types of evidence that we need to answer those questions, then we can ground clinical judgment in the dyadic relationship between the patient and the physician. And so I'm going to turn it back to, after that incoherent ramble, to somebody who's a much clearer thinker.
Thank you, Ross. So I just want to conclude our talk briefly by returning to Feinstein's original arguments in clinical judgment. So recall that Feinstein broke down clinical judgment into therapeutic reasoning and environmental reasoning. And for Feinstein, it was the environmental reasoning that focused on individualizing management for a particular patient. So what we'd argue is that although the data-driven statistical approaches can be useful in the clinical encounter, they don't adequately address this environmental reasoning, and what we need is to develop this. And so some of the approaches that Ross mentioned, the virtue-based moral ethical approaches, as well as the narrative and hermeneutic approaches, may be ways to further elucidate this environmental reasoning. So now we want to go back just quickly to the clinical case. So recall Mrs. Scott. She's our elderly patient with multiple medical conditions. She's been struggling since the loss of her husband 15 months ago. She has a precarious financial situation, and her daughter's worried that she has dementia. So how would you approach this case? Well, you could apply the classic EBM toolkit, the statistical tools. There's a JAMA Rational Clinical Exam article for this question here, does this patient have dementia? You can apply the standardized cognitive tests, the MOCA here, Montreal Cognitive Assessment. You could even apply a geriatric depression scale. I can do this stuff now on my phone, actually, and there's actually even, this is my favorite one here, Bayes at the Bedside, where I input a likelihood ratio and it generates a post-test probability. And I can hear Gadamer rolling in his grave. He said, instead of learning to look, this was quite a prescient remark, I thought. He said, instead of learning to look for illness in the eyes of the patient or listen for it in the patient's voice, we try to read it off data provided by technologically sophisticated measuring instruments. Both are perhaps necessary, but it is difficult to practice both together. So, Mrs. Scott, we can apply the statistical tools, the clinical decision aids. In the future, we may be able to apply predictive analytics to generate prognosis or diagnosis. We can narrow our differential diagnosis here, but ultimately what's required in the clinical encounter is that we attend to Mrs. Scott's narrative. We need to engage in an open dialogue with her. We need to appreciate what she means by her sadness, her context, and her functioning. We need to understand her social determinants of health as well, which are often not considered by the statistical tools. And we argue that this pluralistic approach is really what's essential to determine how to communicate and how to act in this particular instance. So with that, I'll end our talk. Thank you very much. We're happy to take some questions with the time remaining. So thank you. Yeah. I just want to remark, too, that if we have a microphone here for questions, they will be recorded, the questions. So if you don't want to be recorded, you can just shout out the questions and I can repeat them. If you want to go up to the mic, too, that's fine. But sure.
So thank you for the talk. Is this actually on? We're good here? Okay. Yeah. So I'm Matt Mercury, McMaster University, and I guess University of Toronto as well now. So thank you and happy birthday.
Oh, thank you.
You know, I think you nicely outline, I guess, the push, the agenda, I should say, of pushing the statistical reasoning on your training,
Mm-hmm.
right? And now we're going on roughly, I guess, 30 years since Sackett wrote his first paper and 25 years since the paradigm shift. And yet, guidelines are not being followed, right? And I guess I'm wondering if this is just more of an issue of rhetoric or if this is actually a dire situation for medicine. Because I feel as if physicians are responding to the narratives despite all of their training pushing the statistical.
Excellent. Yeah.
So where do they learn that?
So I think that just going back to sort of the distinction that we said at the outset in terms of the descriptive and normative approaches, we take it that our account, somewhat ambitiously maybe, is both descriptive and normative. So we think that what we're describing here and what Professor Montgomery describes in her book too is the actual work of good clinicians. Really, they do attend to the narrative. They do engage in this hermeneutic process, whether or not they articulate it in this way or not. So I think that this is what we need to focus on. And I think that really what the danger, that the reason that we're sort of advocating for these approaches is because the danger is that because this component of clinical judgment hasn't necessarily had the same emphasis recently in, like you mentioned, the paradigm shift in evidence-based medicine sort of sweeping across the field of medicine, we think it's necessary to emphasize this stuff because I think this is what good clinicians do, and I think it's important to really elaborate that. I think the question about implementing guidelines into clinical practice, I mean, Ross is someone who's written a lot about guidelines, and I think that really it speaks to the fact that these guidelines are often difficult, if not impossible, to apply because of the sheer number of guidelines that apply to any individual patient, especially a patient like Mrs. Scott, and then also the fact that these contextual factors are not necessarily incorporated in any meaningful way into these guidelines. I think those are really the key things, as well as the patient values. And I think that's why we're sort of emphasizing a pluralistic approach here. I hope that answers.
Oh yeah, no, I completely agree with all of that. I guess my concern more of is where are people learning it, right? Because they're clearly learning it, right? And so are we worried that they're going to unlearn it if we stop emphasizing it, or?
Well, I think, like, just speaking from the perspective of a trainee, I think that certainly the opportunities that I've had to learn those aspects have been sort of by mentoring and modeling on the work of expert clinicians working in the field. And I think that, so what we worry about is that these approaches may, because of the emphasis on a lot of the data-driven statistical approaches within medical education, we worry that these aspects are going to be lost, and then this will be sort of, this knowledge is not going to be available to future trainees in the same way. I guess that's sort of what I would say. Thank you. Yes.
Are you thinking of judgment as something that we can't yet formalize, or that can't be formalized in principle? I don't know what I think about that, and I've been thinking about it a lot in the context of causal inference in epidemiology. It's different, but it's a different field, but there's a lot of parallels. Talking about pluralism and stuff. And the thing that always bothers me is, on the one hand, you can see why formalists get frustrated by appeals to judgment, because if we do it, why shouldn't we, in principle, be able to describe it? And if we can describe it, then in principle, we should be able to formalize it, because formalizing is just a kind of description. On the other hand, attempts to do that seem to fail, and it's very hard to see how they could, in principle, succeed. So I just wondered if you'd thought about whether you see the judgment element in the clinic as being, in principle, unformalizable, or whether it's just a contingency of our present state.
That's a great question, Alex, and I think about that question every day, to be honest, and I vacillate back and forth. So I think it's probably in principle not, well, there might be more than one formalization. So I've been doing a lot of study of formal systems and philosophy of mathematics, and there's various different ways that you can formalize something. Is there something that would actually formalize the totality of things that we need to know to do good clinical work? Probably in my imagination, but in the temporal horizon in which I inhabit, likely not. So then I go back and forth to say, well, what am I then committed to a formalist approach entirely? It's just a temporal thing, or is there something there in that sort of, I'd say, irreducible epistemic uncertainty that would actually preclude us from ever having a completely effective 100% formalism that the people in predictive analytics think that they can get?
Can I follow up quickly? So then the question then is, should people continue to make strenuous efforts to formalize these sorts of the form? I mean, that's where I think it gets interesting.
So what I think we have at our disposal is a family of logics that get us not so much bothered too much about the sort of axiom. I guess we have to specify when we're talking about formalism, or is it going to be based on an axiomatic type of a system? Or can we use something like the family of defeasibility logics or defeasible logics, where you're using provisional reasoning that allows you to update? So it's got some elements of the Bayesianism that is going to be spoken about, but it also admits premises and propositions that aren't particularly or necessarily quantitative in nature. And I've spent a couple of years trying to figure that out, and hopefully we'll get there someday. But that's a fabulous question.
Thanks.
Thanks.
Great. Excellent.